All right, great. Okay, starting. Wow, this is a tough panel. There's a lot of successes. I think this is more of a works in progress compared to my colleagues, but we'll see what we can get out of it. I have nothing to disclose. I'm, especially for the next 4 years, looking to update the slides, so if you have anything to add, please let me know, but I have nothing to disclose. Okay. Well, what's great is that my panelists have done a great job showing, and I know everybody here knows that there's a lot of groups endorsing screening for social drivers of health, lots of standard-setting organizations, professional organizations, U.S. News and World Report, which we do everything that they say, but it does move the needle on some things. And a lot of them are endorsing, especially inpatient screening for food, housing, transportation, utilities, IPV. And particularly, one of the Health Affairs article that Caroline and Laura and others put together showing that there's also some endorsements for interventions, including sort of providing resources within 30 days or providing some sort of follow-up. So this has really led to a lot of health systems playing catch-up and trying to implement protocols to screen for social risk factors and to address them, including one health system in San Francisco. So, and really what was driving this was with CMS in response to their endorsement to screen for social drivers of health in the last year, led to UCSF Health having starting to pilot screening for social risk factors in multiple clinical settings to sort of inform their implementation throughout UCSF Health System. And as part of these pilot groups, they wanted to include a social health and referral platform, or SHARPS, what we call. The one we use is FindHelp, and so this is an electronic health record integrated referral platform. So UCSF Health had all of these pilot sites over the last year implement social risk screening protocols using this EHR referral tool as well. And so our objective was to understand the reach, efficacy, and adoption of the SDOH screening and referral protocols using FindHelp, as well as the attitudes about the implementation process in the multiple clinical settings in which the pilots took place. So the settings were 2 general pediatrics ward. We had a transitional care unit ward for pediatrics where there was sort of a higher level of acuity, 2 adult general medicine wards, an ED, 1 pediatric diabetes clinic, 1 adult cancer clinic, and then 2 population health groups based in San Francisco, but that would call patients in all of the surrounding counties, but we're based in San Francisco. We use Epic, and there are several tools available to help with screening, including sort of the Epic SDOH wheel, where you can sort of hover over icons. They lead you to screening questions. You can click on them. They turn colors red if they screen positive, green if they screen negative, gray if they're not screened. And so you can see these visual reminders that show up in the EHR for different people to visualize, and it can also be integrated in different windows in the patient record. So that was one tool that was sort of rolled out that they wanted all pilot sites to be using for documentation. Also, this is FindHelp, which there are different referral platforms that exist, some that are third-party systems, some that are home-built, some that are, there's a lot. I'm sure you've seen a bunch here today. And the way that FindHelp works is you can type in a zip code to look for different social resources in that area, and then it can lead you to sort of a sheet of these resources that you can click and print them out for patients. You can also provide referrals and send application information if you get permission from the patients. And community-based organizations or CBOs that do onboard even have the potential to receive some of this information and provide information back if they participate in using the tool. So this was also something that pilot sites were using. Finally, we had a tool called the CRD, the Community Resources Directory, which Epic allows you to basically put in community resources that you can then put in and print out for patients in after-visit summaries. So these were all sort of tools to help with documentation, screening, and providing referrals to patients during the pilot period. Oh, there's another. This is what I'll show you in the after-visit summary. So you could put the list of resources and they print out for patients. So we had all the pilot sites. We asked them to choose and implement screening and referral protocols with at least one of the following: food, housing, transportation, or utilities. And they were encouraged to use, again, that Epic SDOH wheel to document. to use Find Help to find resources and provide referrals if applicable, and then to document the resources using the Community Resources Directory, the CRD. The pilot sites got support with team leaders. There was a learning community and consulting sessions that happen every 2 weeks, and the sites were sort of encouraged to use their QI methods to sort of implement and improve screening and referral rates. Okay, briefly, I'll say that there's lots of different ways people were doing this. So the emergency department, they chose, you can see the big icon of an apple, they were doing food, and they chose to have nurses screen patients when they were being seen by them, and then immediate needs, like if they needed food right then, were taken care of by nurses, and then high-risk patients were referred to social workers with a warm handoff. Population health, oh, wow, that changed text. Anyways, so they were screened per the unit protocols, and then after discharge, automated calls were sent out to patients where they could identify social concerns. Those who were screened positive or had high risk in terms of the follow-up phone calls were then referred to social workers who called and did further assessment, and they focused on food and transportation. For pediatric diabetes clinic, front desk staff gave paper screening questionnaires. Medical assistant entered that into the system. And then a clinician educator provided handouts with resources with escalation to social workers if the patient wanted to speak to them. The cancer clinic basically sent all new patients a screening questions through MyChart, so sending out electronically, and then they gave them the number to call for a navigator if they wanted to have more information, and then higher needs were referred to a social worker, and they screened for all 4 domains. And then finally, for the inpatient units, nurses screened everybody for all 4 upon admission. And then peds social workers tried to prioritize seeing any families with positive screens. And then adult social workers tried to triage positive screens by opening the chart and seeing if there were which patients had the highest acuity in terms of needs. And all of the after-visit summaries for the pilots got this that basically said if you need help with resources, scan this QR code. That would take you to the UCSF branded Find Help webpage where you could search for resources yourself, or and also the number for 211. So we use the RE-AIM framework to sort of guide our implementation evaluation. And we did a couple of different things. We extracted EHR data to look at screening rates and referrals. We tracked the QR codes that we put in people's after-visit summaries to see if people actually use them. We gave staff surveys at baseline and then 7 months after implementation about their experiences. We did pilot site leader interviews at 6 months, and then focus groups between 6 to 8 months. I shall say we're still in the middle of this right now, so we've got three focus groups done. And then we invited the focus groups based on those with high screening rates and low screening rates and put them in different rooms. In terms of our methods, we did tabulations of the screening and referral rates, QR codes, and staff attitudes. We compared rates of different metrics using chi-square test, and did a rapid qualitative analysis of focus group and interview data. Okay, very preliminary results, hot off the press. So this involved roughly 14,000 patients. Staff surveys was 151 baseline, 84 follow-up, about a quarter response rate, and then 14%, and then 3 focus groups and 7 site leader interviews so far. All right, I'm going to show you a lot of things on the screen. Just focus on what you want to. Don't read everything, please. So what I'll show you here is that this is basically showing the staff attitudes at baseline, and strongly agree is on the right side in blue, and then somewhat agrees in purple. And you can see overall, most staff were pretty much supportive of this, saying information about social drivers can be used to improve care, can be used to improve communication. Really, so very much supportive. That last graph on the right was, I am concerned about that collecting information on SDOH data may contribute to bias and or discrimination. So that's the one that's more of a bell curve. This is looking at screening rates over the implementation period. I'd say, again, I'll show you a lot of slides. This is the first one. I'd say the point is that what happened in month 5. So halfway through is when we turned on in Epic the screening, and this is, inpatient units only, which is where we have the data thus far. So basically nurses, when they were asking patients about allergies and everything, when they were settling them, these questions were embedded there. And so that happened in month 5, halfway through, and that happened for most of the clinics in month 5, and then the last clinic in month 9. And so basically, after that was embedded in the workflow, nurses were just going through and asking them pretty consistently, up to like 80%. Rates of screening in outpatient clinic is roughly 45% in the cancer center, 68% in the diabetes clinic, and the emergency department less than 5% for those domains. Okay, bear with me with this. Okay, so this is on the bottom here. This is the number of unique different staff members. This is a Pareto chart, and the percentage of screenings that occurred. So this is staff member 1, 2, 3, 4, staff member, so it goes up to staff member 586. And what you can see here is the classic, 80-20 rule, but not necessarily. So you can see if you go up from 100 staff members out of about 600 screened for 80% of the screenings. 200 of the 600 staff members did basically 97%. This is all staff members that are involved in all the clinics. The charts look the same when you look at different clinics or different units. So it's basically, as you might guess, and from my colleagues' data, some people are doing most of the screenings. We are stratifying by things like race, ethnicity, and language to look at decline rates. None of them are statistically significant now, except for age group. You can see those 45 to 65 declining at a much higher rate than others, although you do see some suggestion based on race and ethnicity of sort of differences in rates of decline. It's almost significant there, but something that we're really trying to pay attention to and make sure things are patient-friendly. Okay, now, here's the help to look for the next couple of slides. Just look at one side or the other, they're the same. Pre and post, everything is the same. The p-values, they're all not significant. So whichever one you like better, look at. And you can see I support efforts to assess and address SDOH in clinical care, so still support. People thought it should be a standard part of care. People thought that their site had the dedicated staff to commit to this. We thought maybe that would help, but it didn't change. Collecting information is beyond the scope of care at my clinical site. That was always strongly disagree and stayed the same. And there's a clear workflow. Unfortunately, that did not really change pre and post. And confidence was relatively high pre and post and stayed the same. I can use information and medical decisions and care planning about SDOH. And I'll just let you all read these quotes, but I'd say that the qualitative findings, the barriers were time, saying, it could take forever, to do this, competing demands, it's laborious when we already have such extensive documentation requirements, lack of resources, worrying patients are saying, why are you asking me if you can't help me? And then logistics, some people still have shared patient rooms and they're worried about asking this. Some facilitators were framing the families, saying we asked this to everybody was really important. Knowledge of follow-up, so when people heard what was done with the results, it really motivated them to do it. And then also time, saying people spend hours here, so it's a good time to check about these things. All right, again, don't strain your eyes. Blue is a facilitator, red is a barrier, and I will just point out here that time needed to screen is a common barrier that's cited in the most common thing. This is just, again, sort of different. For the sake of time, I'll go through these, we could show, but none of them changed pre and post. In terms of searches for resources, this is looking by raw number, and you can see over time just sort of the numbers that we saw. There was 2,300 searches over the pilot period. Most of them were for food. The second most common was for housing in terms of the type. This is looking at there were actually only 289 resources documented in the CRD. That doesn't mean they weren't given, but in terms of documentation, very low rates of documentation, you can see there. The highest was in the Peds Diabetes Clinic, about a quarter. And this is a percent of patients screening positive who had a resource documented given. This, I think, I find the most interesting slide. So this is the QR code data. This is raw numbers, not percentage. The red is people that use the QR code looking for resources that screen positive for at least one thing. The green is people who screen negative for everything. They're still accessing it. The green-gray is people that had at least one thing that they screened negative for but didn't answer all the questions. And then people who declined all of them is gray. So I think the important thing here is the numbers. I would say we're just not getting a lot of engagement with the metrics, but I would say the fact that people who are screening negative are accessing it is important to say that it's not necessarily a resource you just put to the people who screen positive. The one thing, for the sake of time, I'll go here, nothing changed about attitudes about using Find Help or using the Community Resource Directory, except, unfortunately, the support using Find Help on my clinical site was the only significantly different thing that slightly went from strongly agree, the percentage went down a little bit, but still overall supporting using Find Help at clinical site. Again, nothing changed about community resources, saying I understand how to use it, I can easily integrate it in my workflow, nothing changed. I could see the potential value, nothing changed. I support using it, nothing significantly changed, although suggestion. And I'll say, in terms of having the resources, referrals, nothing changed. And again, for the sake of time, I'll go through this. Sorry, too much data. I just wanted to show one thing we measured was burnout. And the punchline is burnout, saying screening for patients for SDOH contributes to my feelings of burnout. That did not change. Health system's emphasis on screening patients for SDOH did not change. Providing resources to address patient SDOH contributes to my feelings of burnout did not change. And health system's emphasis on providing resources to address patient SDOH contributes to my feelings of burnout did not change. Now, there's still people that said it contributed to their burnout, but at least the implementation did not seem to change this. So I will say, I saw 1 minute, or time's up, so I'll say in 10 seconds, the conclusions are staff were generally supportive of screening and referral protocols. Implementation led to varying rates of screening adoption, but lower rates of referral documentation, at least. A minority of staff performed the majority of the screenings. Time is a common barrier to both screening and referrals. Comfort in screening was actually a common facilitator of screening and referrals. There was some decrease in referral tool support after implementation, and then, importantly, implementation did not seem to change staff burnout substantially. So. And thanks to everybody, especially my collaborator, Amelia DeMarcus, who was my partner in this work. Thank you, and please email me for all the slides I didn't tell you about.